So good morning, everyone. It's Tuesday, the 9th of June. I hope everybody is well. So good morning to you. So I'm going to give you a couple of updates this morning. Feel free to use the chat bar if you've got any questions, and at the end of the webinar, I'll have a couple of minutes to answer any questions as well for you. So the first update I'm going to give you is about ERD prescriptions. So just so you know, there's been a temporary change for the need for consent to enable the increased use of ERD prescriptions. So it's always been the case that patients need to individually consent to receiving their medication in this way. But using the powers granted by the National Health Service and the amended regulations in 2020, the Secretary of State has agreed that practices in England may transfer any clinically stable patient onto ERD if they're receiving or have agreed to receive electronic prescriptions. And what does that mean for us in primary care? So any patient who's previously had medication dispensed by EPS, or any patient who has recorded a nominated pharmacy either via the practice pharmacy or the NHS app, or any patient who is in the EPS phase 4 and use that service, which has started this week. So that sort of consent is not required and suspended until the 30th of June, at which time the suspension may be either extended or revoked. So it's a good time to get patients onto ERD. So the next update I'm going to give you about is, so the second update is going to be about really about the clinical side here. So what are the after needs of inpatients recovering from COVID-19? So I was reading a paper that was released earlier this week, and I thought I'd summarize it for you because it's got some really important things about how we can think about people coming out of hospital and what it means in terms of their long-term health. So the first thing I wanted to focus on was when we think about what is the long-term risk of lung fibrosis in these patients. And what we know is that approximately 30% of survivors of this disease, particularly of MERS, for example, have had radiological signs consistent of fibrotic lung disease. So we're anticipating actually that pulmonary fibrosis is likely to be the same in consequence of COVID-19, something to be aware of. And a similar thing can be said for bronchiectasis. So we don't have figures, but we think probably 5% of people with COVID-19 pneumonia may go on to develop it. And so what does that mean for us in primary care? It means that we need to think about the increased morbidity and consider the need to place sort of services, and certainly I'll be bringing this up with our respiratory colleagues at the hospital, but it might be something to bear in mind when we think about these patients, because when they come back in a year or two and have had this cough, actually, do they have this, and do they need a sputum, for example, is what we would do for them? Do they need a 2-week course of broad spectrum antibiotics like amoxicillin or Augmentin? Do they need a respiratory review? Something to bear in mind in these patients when we see them. The next thing is about anyone that's had a cardiac complication. So actually, as we know, myocardial injury is a common cardiovascular complication in COVID-19, and it can affect about 10% to 12% of those discharged. And in that, 12% can have heart failure, and also peripheral arterial disease is often underdiagnosed in these patients, and sort of arrhythmias as well. So always think back to last year's LCS about AF, and are these patients, are they in the 10% who have undiagnosed AF or something else? And then the other thing to think about is hospital-acquired muscle weakness. So we know certainly that people that have been in ITU, for example, end up with something called ICU AW, which is intensive care acquired weakness. And you can see that in nearly 50% of patients. So, it's really key to be aware of that as well. And that can happen for several years. And some people say it can even go on for 5 years after discharge. So it's a really important thing to be aware of. And then also thinking about fatigue. So a lot of people come out and say they're extremely fatigued. And actually, we can say that some of those people, in fact, up to 10% can end up with chronic fatigue before they return to sort of gradual activities of daily living or to their sort of way of living before. And then the final two things are to think about PTSD, or anxiety or depression or any kind of mental health problems being exacerbated by this. So there's a suggestion that 40% can have a form of anxiety, 30% depression, or 20% post-traumatic stress disorder after an ITU stay in particular. And that can sometimes go on for up to 2 years in patients. And just to think about alcohol when you're talking to these patients in case they're using that as a means of feeling better, when we know that actually makes them more depressed, but people often do turn to alcohol. And then the final thing in this is just to think about ADL. So often people have difficulties with activities of daily living, including personal care, sort of washing, dressing, toileting, feeding, and sort of domestic tasks, including cooking and cleaning, or leisure activities. And this can actually be a really important change to their life for the first few months after a hospital stay. And it could place increased pressure on sort of occupational therapy, rehab, and all those kind of things. So those are the kind of things that you should certainly be aware of. And I know that Charlotte's mentioned in the chat bar that we're in discussion with the Respime about a COVID hotline, and I think that's a really great idea. But as we know, there's not been a huge amount of COVID around recently, unless there's a second peak. But certainly we are seeing a lot of post-COVID patients and how we're managing with them. And that's a really important thing to be thinking about right now. Certainly we're seeing quite a lot of people who have kind of got that post-fatigue or feeling quite low and down. But I suppose a lot of people have adrenaline going on right now because, they're still in that heightened phase. But I suspect in the coming weeks, if things calm down, and some of those sort of depression and anxiety might come back. The final update I wanted to give you this morning was just a really reminder about antibody testing. I know I talked about this on Friday, so a lot of people have been texting me about it during the week. So I just wanted to go over that again very quickly. So absolutely, this is voluntary and it's for all staff currently in primary care. And it's not currently available for our patients, as we wanted to prioritise staff at the moment. And there are several thousand staff across NCL. So there's going to be significant pressure on the labs to process all of those samples. So some of you might have even had your results. The results are taking about 2 working days. I've had my result already. And it's just a yellow top blood test. But what's really important is to understand what 3 results mean. So I just wanted to go over that because this is the biggest a reason I've had questions. So if it's detected or positive, that means that somebody has had exposure to the disease at some point, probably more than 2 weeks ago. And then if it's an equivocal result, that means that there's a weakly reactive antibody, which is difficult to interpret, and you should repeat it in 2 weeks. And if it's not detected or negative, there's no evidence of an infection. But what's really important is that it takes about 14 days after being ill to detect antibodies. So if somebody's actually feeling ill, you should not do this blood test. And then remember, if they do test negative or not detected and they do become unwell, they should then follow the government advice to self-isolate and get a swab done through the Gov website. And then staff can retest after 6 weeks if they need to at that time. The final thing, what's really, really important, whatever the result for our members of staff or ourselves, whether it's positive or not, you must continue to follow guidance on infection control, PPE and social distancing. And if you become unwell again with typical COVID-19 symptoms, you should be tested, self-isolate along with the household contacts until you know the outcome of your test, or you've completed your period of self-isolation, whichever is longer. And that's really, really important for us just to remember. And the very final thing, I just wanted to just give you a reminder about Consultant Connect. It is available for our specialities. There's been enormous uptake in Barnet, which is fantastic. So I've had some really great feedback. But if you do have any other feedback, you can contact myself about Consultant Connect or Consultant Connect directly. They do send out regular emails, and I think they're going to be sending out an email today as well, or tomorrow. Just a reminder, the service is available to complement ERS advice and guidance. So I'm going to stop there this morning, and I'm going to ask if anyone's got any questions, just ask away or use the chat bar. So I'm going to pause for a minute for any questions. Okay, if you've got any questions, do let me know, and you can always save them up for Friday if something comes up, and use the chat bar ahead of the meetings as well, so I can look at the questions in advance if there's anything you want me to answer on Friday. But otherwise, what I'm going to say is it's a nice sunny day today. Have a great morning, and I will see you all on Friday.
Thank you.
Thanks so much, everyone. See you Friday. Bye.
Thanks. Bye.